Hi, everybody. We are going to spend some time today discussing LGBTQ healthcare issues in pediatrics. So, while same-sex marriage is now legal, and this was a huge win in 2015, I think it is quite clear that equality and fundamental rights still have a long way to go. For example, this map shows states that have laws against conversion therapy. So 29 states still allow behavior modification to try and quote unquote cure or repair sexual and gender identities. And this is actually a holdover from the era of the term homosexuality existing in the DSM. Historically, the terminology was changed in 1974 to be called sexual orientation disturbance, and then that was then modified to ego-dystonic homosexuality in the 80s. That then became sexual disorder not otherwise specified. This language remained in both the 1994 and 2000 editions of the DSM-4, and we finally see it disappear in the DSM-5 in 2013. So not very long ago, right? In this map, we've got blue states illustrating those that have anti-bullying protection in schools against students based on sexual orientation and gender identity. So this is still leaving 26 states without those protections. And then almost 40% of trans youth aged 13 to 17 live in states with policies that are limiting their access to gender-affirming care. So why do we need LGBTQ content in healthcare education? Well, LGBTQ people and communities have too often experienced discrimination and poor care, and legal rights don't always mean that people are treated with dignity and respect, right? This is an overarching theme in healthcare, is it not? So there's also little accurate information in our culture about LGBTQ people. The information that's coming out often comes from families or schools or religious organizations or the media that still contain a lot of myths and stereotypes. Healthcare professional education currently doesn't contain a whole lot of information to help counteract those stereotypes. There's been some research done about this. There's a literature review from 2005 to 2010 that found that nursing journals rarely address LGBTQ topics. And I want you to think about if you think things are different now. Because a lit review was done that found that less than 0.2% of research articles in the top 20 nursing journals addressed sexual and gender minority health. And this includes AIDS and HIV and pre-exposure prophylaxis uptake research. So this includes what's long been a huge focus since the 1980s, right? So that makes you wonder how much space is actually left in that 0.2% that includes gender-affirming care, healthcare disparities, and mental health research. I would guess that the numbers are pretty abysmal. Some research has been done on BSN programs' readiness to teach about LGBTQ health. They surveyed 1,231 nurse educators from accredited schools of nursing in the U.S., and here's what they found. Most faculty don't have the knowledge or the preparation to do so, okay? About a quarter weren't even comfortable talking about it, so we have a long way to go in this space as well. So why do we need to educate? Well, LGBTQ people and families make up a significant portion of the healthcare consumer population. We all have a sexual and gender identity, so understanding these issues helps everybody. The last several years have seen progress. I think we're starting to accept that human identities exist on a spectrum, and we've known this about the animal kingdom for a long time now, but for some reason, humans just hate to recognize that we are animals as well. This is the true story of Roy and Silo, called And Tango Makes Three. This was a story written about two male penguins at the Central Park Zoo who became inseparable, and when the zookeepers gave them a motherless egg, they successfully hatched baby Tango. Now, this book, probably not surprisingly, has been banned and challenged in libraries and schools, and I've made it a point to read banned books to my girls, so we read this one several years ago, but I bring it up because gay children exist. Gender non-conforming children exist. Children with gay parents, grandparents, aunts, and uncles exist, and representation matters, especially for children. And that's who we're talking about in this class, right? So as discussed in the preschool lecture, gender identity is formed around age 3, and children can recognize the gender of others by age 6. Disorders of sex development are conditions that result in a discrepancy between the external and internal genitals. Klinefelter syndrome can lead to intersex characteristics as seen in this chart. And while there are still limited studies, what research has been done shows an increased incidence of gender dysphoria among children and adults that have disorders of sex development. So we're going to talk a bit about disclosure to healthcare professionals because this is where it all ties together for us. I've seen some progress in this arena, specifically at Carl. We now have a preferred name on the chart, but where I tend to see it fall short is in communication between caregivers. So as we move through this discussion, I want you to reflect on these questions here based on your current clinical or work experiences. And while you do that, I'm going to share a few examples from clinical to give you some ideas of what I have seen and maybe some approaches to use in the future. So I mentioned communication being an area of improvement in PEDS, and this comes from a few different patient experiences. I've had a few students care for trans or gender nonconforming kids who were either not told ahead of time by staff or told that their preferred pronouns or gender identity were unknown. Now, there's a lot of nuance in these situations because even as a staff member with the best intentions, it might be difficult to ask if a parent is present since we don't know what the family dynamic is, right? If that child is out, if their family is accepting, and we definitely don't want to create an unsafe environment for that kid when they leave our care. So I don't have a great 100% answer for you here. I wish I did. I think one approach could be to ambulate with that kid, maybe take that kid out of the room if you truly, feel that acknowledging their identity would be helpful in that scenario, rather than maybe asking the parent to leave or trying to talk to them in front of family when you don't know what the situation is. Another student was caring for a 6-year-old boy who was by himself. His parents were out for the day, and so she went in to hang out with him. And during that time, she decided to try and answer some of her paperwork questions. So she asked him where his mommy and daddy were that day, and he just very bluntly said, "Well, I have 2 moms." And he was totally unbothered, but she was horrified with herself. And she came out to me and shared, and I reassured her that, he probably got that a lot and wasn't really thinking twice about it. But it really exemplified the need for gender neutral terms when we deal with patients, because our experience is not always the experience. And families come in all different configurations. And we're going to see that a lot in pediatrics. You just can't assume a nuclear family, much less any number of family configurations and dynamics. And because family is what we define it as ourselves, we really just can't make those assumptions, and kids will call you out on it if they feel like they have to. So we're going to talk a little bit about the deadly effects of stigma. Okay, so what is a stigma? Well, it is being perceived as belonging to a group about which society has negative attitudes or considers to be deviant, right? So it sets up this us versus them mentality, or a system of othering. Now, stereotypes lie at the root of homo, bi, and transphobia, which are not real phobias, by the way. You may have learned some stereotypes yourselves while growing up. Society is making some progress here, but I can think of so many references in older movies and TV shows that just wouldn't fly today. So what is gender normativity? So this is an institutionalized belief that there are only 2 sexes and that you stay the sex that you were born all your life, okay? And that your gender comes from that assigned sex. So femininity comes from being in a female body, and masculinity comes from being within a male body, and any sort of variation can be harshly punished in our society. So I want you to think a little bit about the taunts that you heard maybe when you were growing up, right, on the playground or at school, and think about which of those insults were gender-based and which were based on perceived sexuality. I honestly don't really ever recall kids teasing each other when I was in school and saying, like, "You're not strong enough to climb those monkey bars." They always gendered it. It was never based on any sort of inherent skills or anything like that. So think about that a little bit and see if, you had that same experience. Now, the stigma that steps from these phobias can be internalized by those who identify as LGBTQ and can manifest as shame and guilt, self-hatred, and self-destructive behaviors. And then, of course, there are intersections of oppression. We don't want to neglect this, that many LGBTQ people also belong to stigmatized groups, which just compounds their level of stress, right? So that can include things like sexism or racism or classism or ableism or anti-Semitism or Islamophobia or any other xenophobias. And so you can have inclusion in these different stigmatized groups, and it just compounds the oppression that someone might be experiencing. So now, what are the effects of stigma on pediatric health? Well, with almost 10% of adolescents between the ages of 13 and 17 years identifying as gay, lesbian, or bisexual, the need for compassionate, educated care is huge. because the health effects can be very significant and can include things like gender dysphoria, bullying, violence, substance abuse, difficulty to access mental health resources, and domestic conflict. The social effects of stigma can lead to lack of recognition of relationships and family, because family definitions are narrow and exclude a lot of LGBTQ families. Some jurisdictions still don't allow same-sex couples to adopt. And then 20 to 30% of LGBTQ people have experienced violence due to their sexuality or gender. Looking at this graph that shows parental rejection, parents who have a high level of rejection for their children can see there's like 70-60% rates of illicit drug use, depression, and suicide attempts. It's important to note that the other bar here is low reaction. So this is not acceptance. This is comparing the high rejection parents to ones that have low reactions, which I'm assuming is more like apathy rather than acceptance. But we have almost 3 times as much incidence of these situations in the high rejection families. So it's very significant. LGBTQ young people are more than 4 times as likely to attempt suicide than their peers. And then the Trevor Project found that 41% of LGBTQ young people seriously considered attempting suicide in the past year. And this actually includes roughly half of transgender and non-binary youth. And then those numbers are even more apparent when we break that down into minority groups. So there's quite a discrepancy there. So talking again about family dynamics, okay, so family is defined by legal ties, blood ties, and affinity ties, right? People that are important to us. So which definitions do you think should be used in healthcare settings? Just reflect on that, on what your personal opinions are on it. Same-sex marriage, as I mentioned at the beginning of the presentation, is a fairly recent phenomenon, right? 2015. And children in these relationships or in these families can come from previous or current heterosexual relationships, from alternative insemination procedures, from adoption, and from co-parenting. So again, like multitudes of different types of family configurations that we can find. Most of the research on children of LGBTQ parents have been done on lesbian couples, but compared to children of heterosexual parents, there are no differences in gender identity or sexual orientation. There are no differences in most measures of adjustment or behavioral problems. And in fact, some studies actually find these children to be more mature and understanding of diversity. Relating to developmental transitions, for kids that are younger childhood, that either identify as LGBTQ or have family that do, they can have issues with fitting in. The importance of their family support in that age. They could be bullied, or they could feel different and not quite know what that means. And as these kids grow up and they start working into their identity formation and the importance of peer acceptance, and they're starting to experiment, they become more vulnerable to victimization from their peers and family. That period of time can also be very important and significant as well. So I want you to think a little bit and reflect on your own comfort level, whether or not you know personally any LGBTQ people. If you feel comfortable saying the words lesbian, gay, bisexual, and transgender, think about if you're comfortable working with LGBTQ patients or clients, and if not, why not? What did you learn about LGBTQ people in the past that created a level of discomfort, and what can you do to ease that discomfort? I think these are all, questions that are really important to ask as we move into clinical setting and as you move into your professions as nurses. And if you are uncomfortable, what are some steps that you can take? Well, at an individual level, start educating yourself, become more aware, reach out to LGBTQ coworkers, family, and friends, and talk to them about their experiences. At the agency and facility level, review and change policies as needed to be welcoming and inclusive, and work to enforce those policies. Really make sure that the staff is acknowledging these policies if they exist. And at a societal level, vote for inclusion rather than exclusion. Challenge injustice when you see it. So in conclusion, LGBTQ patients want the same things from their healthcare experience that all people want: high quality care, safety, comfort, recovery, acceptance, and being treated with dignity. And a welcoming and inclusive healthcare environment benefits all patients and employees, right? And then as nursing students, just keep in mind that you're in a unique position to positively impact a patient's experience, especially I think in pediatrics. I think that peds is a very unique situation where you might be the one positive contact that child might have in that day or that week or that month. And you have these moments that you can create these positive connections with them, and acknowledging their identity and who they're choosing to be, when maybe the other people in their lives are not. And I think that that is a really special place to be. And I think it's a really great opportunity to impact these kids, even though you're only going to be around them for a few hours during clinical.